Bonjour, je vous remercie pour l'introduction, je m'excuse pour le retard et je remercie les organisateurs de m'avoir permis de vous présenter le sujet suivant. Donc, je vais m'exprimer en anglais si vous le permettez. Et donc, le sujet est la prise en charge des obstructions trachéobronchiques dans le cancer thoracique ou the management of tracheobronchial obstruction in lung cancer, and I will discuss the endoscopic treatment of lung cancer. Just to introduce some facts in lung cancer, 50% or less of non-small cell lung cancer are candidates for surgical resection. Survival remain around 15 to 20%, and 30% of those non-surgical patients or even operated on patient will end having bronchial obstruction or obstructive symptoms, with consequences of respiratory distress, infection, and bleeding. The indication for an interventional pulmonologist is tracheal or bronchial obstruction with life-threatening respiratory distress, relapse of after conventional radiation and chemotherapy, hemoptysis, dyspnea, atelectasis, or post-obstructive pneumonia. So the patient will be addressed even after recurrence, after surgery, or failure of chemoradiation treatment, or sometimes acutely with central airway obstruction. There are different etiology for the central airway obstruction. You can have primary airway carcinoma with the usual lung cancer. You can have metastasis to the airway. You can have laryngeal carcinoma, esophageal carcinoma, or mediastinal tumor, or big lymphadenopathies. So you can be dealing with any of those categories. And you have to know what you're dealing with, because some of the tumor may have a semi-malignant behavior, and you'll be able to treat them on the spot while you are doing interventional pulmonology. Just have to keep in mind tracheal obstruction. Tracheal obstruction, patient present with dyspnea on exertion usually. And usually the symptoms appear when the trachea is below 8 millimeters in diameter. Dyspnea at rest occurs when the diameter is less than 5 millimeters, and 54% of the patient would present in respiratory distress. You will have to intervene emergently. Those patients end up in intensive care units, sometimes even intubated. Treatment aspect. Usually, an endoscopic treatment will have three phases. Tumor coagulation to reduce profuse bleeding, debulking of the tumor, and eventually stenting in case of significant residual extraluminal stenosis. And depend on the tumor, on the size, the place, or even the nature of the tumor. And you can have three types of obstruction. You can have endoluminal obstruction, where all the tumor is in the airway. You can have extraluminal endoluminal tumor mixed, or extraluminal with compression. So you can imagine with extraluminal compression, there's nothing to treat in the airway. You basically will have just to dilate the airways and stent it to prevent compression again. So the treatment concept, you are or in palliative care or in curative intent. Curative treatment will be mainly for relatively benign conditions, and we'll look at them now. Malignant tumor in the central airway, non-surgical candidate, and benign conditions. So if it's palliative and it's obstructive, you go to immediate procedure. For curative intent, you will do a tailored treatment according to the nature of the treatment, or a local therapy if you have in situ tumor. Debulking with interventional pulmonary treatment in patients who are not candidate for surgery, or interventional pulmonology for the other. And what are interventional pulmonary for benign tumor like hamartoma, chondroma, and papillomatosis, because when you treat them locally, you have no recurrence. For typical carcinoid, mucoepidermoid carcinoma, granular cell myoblastoma, and fibrosarcoma, also local treatment may be enough. And local therapy for in situ tumor. So what are the tools? Two types, extrinsic compression or intrinsic compression. So if you are dealing with extrinsic compression, you can have stents, external radiation, brachytherapy, or radiofrequency. For intrinsic obstruction, you have different tools: anti-yag laser, cryotherapy, electrocautery, brachytherapy, photodynamic therapy, APC plus minus stents. And we'll deal with laser, with cryo today, with electrocautery, with APC and stents. What's about laser? Laser is light amplification of simulated emission of radiation. And laser has three main characteristics. The power density rating, so how much power, how much you are burning tissue and how deep it goes into tissue, so how much is absorbed and how much is scattered around. And the delivery system, not all lasers can be delivered down in the airway. You just have to keep in mind that laser treatment will deal with obstruction but will not improve ventilation. And those are the different type of laser that we have around. And the one that we use in the airway are Nd:YAG, CO2, or argon. And the different properties of those lasers are the following. Nd:YAG will vaporize and coagulate, while CO2 will mainly vaporize, and argon will mainly coagulate. The advantage of Nd:YAG laser is it can be passed through a flexible bronchoscope or any fibers that go down the airway, so a rigid bronchoscope. It penetrates deeper in the tissue than CO2, and with success would depend on tumor location, appearance, short tumor less than 4 centimeters, and a patent distal lumen. The contraindication for laser is the presence of plastic hardware. Sometimes the patient has stents, you have to be careful, it can burn. If you have endotracheal tube in, it can burn. The objective that we look for is improvement in quality of life. And the adverse effects can be bleeding, airway perforation, damage to the bronchoscope, or airway fire when you are using an FiO2 of more than 30%. And I'm not going I'm just showing you this to show you the study by Cavalier in the beginning of the 80s that published the biggest series of Nd:YAG laser with more than 1,000 patients and having really very low death rate, 5 treatment-related deaths. So they are safe therapy. What are the indications? Symptomatic obstructive lesion of the main airway in inoperable lung cancer with endobronchial manifestation, palliation basically. And as I said earlier, the treatment will not improve ventilation significantly. And the absolute contraindication is external compression. So if you don't see a tumor within the airways, there is no point in doing laser on the airway. The complication we dealt with earlier. And this is just to show you a study using endobronchial palliation using Nd:YAG laser associated with improved survival when combined with the other treatments. So those treatments have to be combined with chemo and radiation to get improved survival. This is a study done in Australia between 1999 and 2004 using rigid bronchoscopy or fiber optic bronchoscopy on 110 patients with 153 sessions of laser, mean age 67%, and 87 treatment with one treatment and 23 with multiple treatment, and the patient had hemoptysis, dyspnea, or cough, different manifestations. And you can see that for non-small lung cancer, single modality and multi-modality median survival was around seven months in the subgroup, and in all lung malignancy, you can have around 7 months of survival. With adjunctive therapy used were brachytherapy, chemotherapy, radiation, stenting, or chemoradiotherapy. And this is looking at another study from Japan, published in 2000 by the group of Furukawa, and showing two groups of patients. And you can see the Kaplan-Meier curve difference between the two groups. Group A not having additional therapy, and B with the additional therapy of chemo and radiation, and see the difference in survival. And you can imagine that sending a patient for chemo and radiation with this type of lesion, he will not be able to go around getting his treatment if you don't deal with this kind of tumor quickly at the bottom of the trachea or on the carina. Lost the connection. It's back, I guess. Electrocautery or diathermy. Probes are passed through the flexible bronchoscope and require direct contact with the target tissue. So this is a contact therapy, while Nd:YAG laser is a non-contact therapy. You can cauterize the vessels to reduce hemoptysis, or you can do tumor debulking. It facilitates removal of pedunculated lesion when delivered through a snare. I will show you the picture later. And the adverse effects are a little bit like laser, bleeding, airway perforation, damage to the bronchoscope, and airway fire. And this is a snare of a lesion at the left main bronchus. You pass the snake at the bottom of it. You put the power, and then you can just cut it through. APC is interesting because it's cheap compared to laser. It delivers electrons through a jet flow of ionized argon gas without requiring direct tissue contact. So it can be a contact or non-contact therapy. It can be performed using flexible bronchoscope in outpatient setting under constant sedation, or it can be used with a rigid bronchoscope. I prefer rigid bronchoscope because, one, you get less wear and tear on the bronchoscope. Repairing bronchoscope is $15,000. Rigid bronchoscope, you can't destroy them. And you can control better the airway under general anesthesia with a rigid bronchoscope. It's particularly useful for hemostasis and tumor debulking. The biggest study is from Morris et al. Published in Chest in 2001. It was dealing mainly with patients with hemoptysis. He had 56 patients with hemoptysis, bleeding resolved in all patients, and you can have debulking of endobronchial tumor with a narrowing going from 76% to 18% of the airway. Adverse events also similar to Nd:YAG laser, bleeding, airway perforation, much less airway perforation because you don't get a deep penetration. Damage to the bronchoscope, airway fire if you don't keep your FiO2 less than 40%. And what's particular about APC, since it's insufflated gas, jet flow, you can have gas embolism if you are next to a vessel. This is just to show you I'm not sure if it's going to show, a video of a rigid bronchoscopy with a tumor obstructing the right main bronchus, and this is Nd:YAG applied to the right main bronchus to basically deal with the obstruction at that point. And you can imagine that when you do rigid bronchoscopy, you can use the tip of the rigid bronchoscope to core out any tumor and basically go quickly with the procedure. Cryotherapy. Cryo will destroy the tumor by applying a repeated cycle of extreme cold followed by slow thawing. Destruction is delayed up to 2 weeks, so this technique is not suitable for acute central airway obstruction. If the patient is choking in the emergency room going to the ICU, cryo is not the ideal treatment. It prevents local recurrence and manages hemoptysis. It's cheap. Complications are airway perforation and hemorrhage, but they are extremely rare. Finally, radiation therapy, it takes 2 or more weeks to achieve a desired effect. Brachytherapy is not superior to external beam radiation, but less side effect with brachy. The complication with brachy is formation of fistula, stricture, bronchitis, and delayed hemoptysis. So basically, to resume the different applied therapy in the bronchus, you have photodynamic therapy. We're not going to discuss today, but it's effective in palliating symptoms and is very expensive and effective in opening the airway. Brachytherapy, cryotherapy, cryo-extraction, laser, diathermy, and argon plasma coagulation. The first 3 therapies cannot be used emergently. Okay, so if somebody is suffocating, you need to go and use laser, diathermy, or argon plasma coagulation. And this is to resume the difference between laser, electrocautery, and APC. The cost, laser, you have to use disposable fiber, and it's expensive, while APC, it's much cheaper, and it's available in the GI suite, in the operating room, so it's available around the hospital. Complications are much more common with laser. Poor maneuverability, you cannot maneuver a lot with laser, especially you need to be careful for airway perforation. You have to have low FiO2, you have to be careful if you have plastic in the airway. It's very effective for laser, for electrocautery, and for APC. Treatment time, laser is the fastest, while APC and electrocautery you need to spend more time because you're going to be vaporizing, you're going to be coagulating the tumor rather than vaporizing it. This is to show you a case. This is the patient we treated in February, actually, with a total collapse of the left lung with a tumor at the bottom of the trachea covering the carina. This is after 3 hours in the operating room with argon plasma, and you open up the whole airway, and we have a good anatomy. And this is to show you what kind of tumor it was. Basically, it was a cystic adenoma, and this is, you can see application of laser on this argon laser. This is it ended up being a cyst adenoma, so it's a relatively benign tumor. If you can deal with it with argon plasma or laser and rigid bronchoscopy, you can basically cure the patient. Another reason to use endobronchial treatment is to prepare a patient for surgery. Now with the new technique, with sleeve resection, when you are dealing with airway obstruction before the surgery, you can help the surgeon preserve more lung, and you can see that lung function test before and after endobronchial intervention in patient subsequently undergoing lung resection. So therapeutic bronchoscopy might permit parenchyma sparing surgery in patients with lung cancer. What's about stents? Stent insertion and indication. You will be putting a stent if you have external compression of the central airway, because as we said earlier, laser will do nothing for external compression. If you have loss of cartilage support of central anal for benign or malignant lesion, if you have a TE fistula in esophageal cancer, we see this a lot, TE fistula between esophagus and the trachea or the left main bronchus, anastomosis failure after pulmonary resection, or maintain dilated strictures. The advantage of stent, you get immediate correction of airway patency. You can have two different types of stents, metal that are permanently placed or removable, silicone. They are easy to place and can be outpatient procedure for the metal stent. It cannot be for the silicone because the patient has to go under general anesthesia. It can be placed through flexible bronchoscope for the metal stent or rigid bronchoscope for metal and silicone. And what kind of stents we have? So those are 6 different types of stents. This is the Roche Freytag silicone stent. This is a Dumont Y stent. This is a non-covered metallic stent. This is a Nova stent. I think this one was pulled out of the market. And this is the Ultraflex stent. The Dumont stent will come in 2 types, a straight and a Y, tube and Y. The Polyflex has been removed, but Polyflex is doing the Rush also stent, which is a Y stent. All silicone stents will require rigid bronchoscopy to be placed. It comes with studs, and comes in different sizes to be able to stuck to the airway. And this is a tracheal tumor obstructing the trachea before laser and stent, and this is after laser and stent. This is non-small cell lung cancer, rigid bronchoscopy, laser to the area, and then putting a stent also. And this is the deployment of a metallic stent, just to show you how quick it can deploy. This is through rigid bronchoscopy. This is trachea also. The tumor has been resected with laser. And this is basically the stent that's wrapped on a long stick, and then you just have to position it and deploy it, and this is just controlling the anatomy after deployment. The problem with those metallic stents, as we said earlier, if they are placed in, they are very hard to be taken out, but sometimes you have to take them out because you get crusting and you get halitosis, basically very bad smell from the patient mouth, but it would take a couple of hours to get this thing out of the airway. The Y stent insertion, you need the rigid bronchoscope to place it. There are different techniques to place it. You can just stick it to the top of the rigid bronchoscope and push it in, or you can have it fold inside the bronchoscope, stick it in the left main bronchus and pull it back and install it on the carina. And you use a Dumont Y stent for carinal tumor. This is a carinal tumor, so non-resectable patient before chemo and radiation, still having obstruction to both main bronchus and having a Y stent placed. This is a small cell carcinoma. You don't get too much on the bronchial lesion in the small cell. This is infiltration of the mucosa. This is putting 2 types of stents. This is post-dilation, two stents. This is post-dilation. Small size on the left. This is a Dumont stent on the left and the Dumont stent on the right. Airway stenting for malignancy and benign tracheobronchial stenosis. When to place a stent. So benefit from stenting appear technically feasible and clinically meaningful. The patient has to have an estimated survival of more than a month to be using those expensive equipment. Usually stents are placed in the main bronchus or the trachea. Okay, you don't put stents in the segmental or in the lower bronchus. So you'll not put a stent in the right lower lobe or right middle lobe or upper lobe. So you put it in the right main stem, left main stem, or trachea. This is the result of multimodality treatment with improvement of symptoms, significant improvement of mild symptoms, 4% minimal or no symptoms, and 1% worsening of symptoms. So basically what we look for in those procedures is symptomatic improvement. And basically this is another paper resuming all the studies were done on patients in the ICU that were intubated and how we can take off the patient off the respirator with minimal complication when you are dealing with put stent in them. Conclusion, treatment of choice would depend largely on the emergency, on the cost, on the availability of the technique you have in your facility, and the experience of the operator. I will stop here and take your questions.
Thank you, Dr. Dabar. Question?
I guess it's clear? Okay.
Actually, I have a question concerning the Y stent.
Yes.
Comparing it to the tube stent, the tube stent, we know that we put it in the introducer to put it in. Does the Y stent get in the introducer, or do you just push it inside?
No, you can fold it in the introducer, but you have to use the largest rigid bronchoscope you have. It's a 14 millimeter bronchoscope that you have to place it in. So you need to dilate the left main bronchus first before inserting the Y stent.
So I guess it's going to be even more complicated opening it inside.
You have to put when you insert it, it will be folded in the left main bronchus. Then you have to retract it to the trachea, and when it comes up in the trachea, it opens up, and you hope that to get the right side in place. Otherwise, you have to flip it 180 degrees to get it there. The advantage of the Y stent is you can cut, because sometimes people have tumor on the carina, but the right upper lobe is open, so you cannot put a stent completely in the right main stem. You will occlude the right upper lobe. So you cut part of the stent, and then you place exactly the size you want. All right. Thank you.